Welcome to AETCM Emergency Medicine Channel. Shall I start, sir?
Yes.
A 31-year-old male patient came with complaints of generalized tiredness, chills, myalgia for the past 1 week to the ER. On arrival, airways patent, no pooling of secretions, breathing, respiratory rate is 18 per minute, saturation is 98% in room air, chest air entry bilaterally equal. Circulation, BP is 130/70 with heart rate 96 per minute, all peripheral pulses palpable, GCS is E4, V5, M6, pupil bilaterally equal and reactive. GRBS is 86 mg per dl, exposure is afebrile. Adjuncts to primary survey, we done CBC CRP point of care, which shows WBC of 9,500, HB is 13.9, platelet is 1,86,000, CRP is 10.3. In total count, neutrophils is 41.5 and lymphocytes is 46.2. And in VBG, pH is 7.45 with bicarb 27.2 and PCO2 39.3, sodium 137, potassium 4.2.
VBG are useful in which all conditions in emergency room? VBG.
Sir, in case of if to look for acid-base abnormalities, we can take VBG primarily, and also we can look for in our VBG sodium, potassium, serum electrolytes values are available.
Where it cannot be used? VBG cannot be used in which type of acid-base disorder?
If you are suspecting any respiratory association.
So if you are suspecting respiratory disorders, better not to go for a VBG, you go for ABG. Otherwise, all practical purposes, this is enough. Instead of pricking the patient multiple times, this is more than sufficient.
And lactate is 1.6 and creat is 0.8 and bilirubin is 0.7. Coming to the ample history, patient has no known allergies, not on any regular medications, no history of chronic illness. 31-year-old male patient presented to the ER with complaints of generalized tiredness, chills, myalgia for the past 1 week. They evaluated in outside hospital and found to have thrombocytopenia. Value is not available. They done dengue test which shown positive. And initial
Dengue, which test they have done?
dengue NS1 done and which was positive.
Antigen.
And initial total count in that hospital is 3,390 with SGOT 52 and SGPT 51. Progressively worsened in that hospital itself to SGOT to 3,709 and SGPT to 6,093. And in initial evaluation,
6,000. SGOT, SGPT in thousands.
OT in 3,000 and PT in 600. 693. And they done.
Does he take alcohol?
No history of recent travel, no history of exposure to stagnant water,
alcohol.
no history of alcohol or drug intake,
Okay.
no history of jaundice, no history of trauma or sternus activity, seizure, LOC. In initial evaluation, CPK is also elevated around 1,58,000 and it is progressively increased to 2,57,000 in that hospital itself, so that they referred here for further evaluation. In our primary investigations, CRP is around 12.59, RFTs are normal, urea is 142 with creat 0.73, urea 14.2 with creatinine 0.73, uric acid is 3.5, calcium 8.53. In our total CK is 1,19,300 and potassium is 4.6 with the WBC 9.76, neutroph with a lymphocyte predominance 53.8, INR is 0.8, and we done urine myoglobin also which shows positive.
Urine myoglobinuria with polymyositis, post-infectious polymyositis.
We initially treated the patient with fluids. Fluids initially we give 1 liter per hour. And followed by 500 ml in a level of 4 ml per kg per hour gall to maintain the urine output between 3 to 4 ml per kg per hour.
What is the need of fluid here?
Sir,
How do you manage a condition like this where polymyositis is there, CK is very high, you anticipate renal damage? How do you manage that condition?
And we have to maintain, in this case myoglobin can excrete through the kidney and it will cause tubular damage to the kidney. So we have to do the diuresis.
So you have to give fluid, you have to give diuretics if required.
If
Post
the urine
diuresis, not post alkaline diuresis, that is different.
if the patient's urine output is good. If otherwise, if urine output is less, if there is dyslipidemia and high creatinine, we
Problem
have to
is
proceed
most
with
of these
dialysis.
patients may have creatinine also elevated. Will you give fluid?
If creatinine is elevated, no urine output, then we have to proceed with dialysis.
If you initially you try with fluids, if there is no urine output, better to dialyze the patient.
So coming to rhabdomyolysis, destruction of skeletal muscle, that is acute
But this
necrosis.
patient never had any muscle pain. Can it happen like that? Normally, when we have polymyositis, we expect some pain. It was not there in this case. Can you get like that? It is possible. It is very well possible. But muscle weakness has to be there. This patient never had muscle weakness also. So it is an unusual presentation of a common disease.
So in case of rhabdomyolysis, there will be acute necrosis of the skeletal muscle. There will be leakage of the cellular contents into the circulation that will lead to myoglobinuria. And most common causes in adults is alcohol intake and drug abuse and all. Medications.
Not drug abuse, drugs.
Drugs.
What are the drugs will produce rhabdomyolysis? Common drugs.
Stimulants, cocaine.
Common drugs. Drug abuse, what you told is correct.
Antipsychotics, SSRIs.
Common drug. Commonly used drug which can produce polymyositis. If you don't treat, patient can get severe muscle pain, statins. Statin, high dose statins, you give for a myocardial infarction or we give 80 milligram per day. Some patients may go to polymyositis.
And in case of antipsychotics, SSRIs, in case of neuroleptic malignant syndrome, and the caffeine, cocaine, heroin and all, and the other environmental and excessive muscular activity like contact sports, delirium tremens, dystonia, and in genetic conditions
what
like...
is March hemoglobinuria? March. Where March occurs?
In following...
April.
No, sir. In
March,
case of marches and all, after that the
like
muscle
military,
muscle
police,
activity.
all these forces, they after prolonged marching, they develop polymyositis, myoglobinuria. That is called as March hemoglobin. Any strenuous exercise can produce that sort.
And in seizures, marathons and all. In genetic conditions like glycolysis, glycogenolysis, fatty acid oxidation disorder, and in immunological dermatomyositis and polymyositis.
That what will be the typical feature of that disease?
There will be rashes.
They have facial rashes, heliotropic rashes, knuckle rashes, all these things.
And in vascular conditions like acute arterial occlusion and persistent large vessel occlusions. And bacterial and viral infections, most probably group A beta hemolytic and Clostridium Klebsiella, Legionella, Salmonella, and viral like Coxsackie virus, CMV.
What is common bacterial infection which can produce polymyositis in our country or a state? Common bacterial. It's a spirochete. What is it? Spirochete infection. There is a common spirochete infection you treat leptospirosis. That is a common bacteria which can produce polymyositis, tropical polymyositis.
And in children it is less common but is more benign, and non-recurrent rhabdomyolysis will be seen in case of viral myositis, trauma and connective tissue disorder. If there is recurrent episodes in both children and adults, we have to suspect any inherited metabolic disease associated with exercise intolerance. And also statin related myopathies are also common. Without elevation of CK, we can see muscle weakness and rhabdomyolysis. It is associated with the statins and also dose related. If it is combination with other drugs like cyclosporin, macrolide, antibiotics,
statin with what? Statin, whatever we are given books will not happen routinely. But statin with a drug, which is very commonly used, that will present with severe myositis. Statin with some other drug. Fibrates. That also used for low cholesterol. So statin with fenofibrate or other fibrates can produce severe polymyositis.
And the mechanism is injury to the skeletal muscle will release the intracellular contents with it leads to the disruption of the sodium potassium ATPase pump and calcium transport that will increase the intracellular calcium, and subsequent muscle necrosis will happen. Calcium will activate the phospholipase A2 and various vasoactive molecules that lead to the release of the free oxygen radicals.
What will happen to calcium in rhabdomyolysis?
Calcium will decrease. And the clinical features...
Potassium?
potassium will increase.
Okay, so these are the two electrolytes or elements which can increase and decrease. Calcium will decrease, potassium will
Potassium
increase.
And clinical features will be acute in onset with myalgia and weakness, with a dark urine possibilities also there, with nausea, vomiting, abdominal pain, tachycardia. Mental status changes also can be possible in case of urea-induced encephalopathy and all. Involved muscle group will be their swelling, tenderness and hemorrhagic discoloration.
Is it proximal myopathy or distal
Most
myopathy?
commonly proximal.
Can you tell one distal myopathy? Only one condition will produce distal myopathy. That is inclusion body myopathy. Inclusion body, but that is not very common. Almost all myopathies are proximal, but whereas neuropathies, most of them are distal. One difference is inclusion body myopathy. That is an exception that can produce distal myopathy.
The most sensitive and reliable indicator is serum creatine kinase, and the degree of elevation is like 5-fold increase above the upper limit.
Okay.
And that should be in absence of cardiac or brain injury, and the levels initially rise within 2 to 12 hours and peak at 24 to 72 hours, and after that 40% reduction will be there by the next day. And the earlier marker is urine myoglobin, but it can sometimes it will be negative also, and because of rapidly cleared from the plasma through the renal excretion, and
Within
also
1 or 2 days patient will recover.
recover.
It will not prolong.
If we see in urine dipstick positive for blood, we have also checked the urine microscopy. If there is no RBC, we can suspect myoglobin. And the monitoring of the patient by serum electrolytes, calcium, phosphorus, uric acid. There is possibility for hyperkalemia, hyperuricemia and hyperphosphatemia with hypocalcemia. And ECG also if there is hyperkalemia present, and the serum creatine and also the coagulopathy also have to be seen, PT, APTT and fibrinogen levels. And once management is early and vigorous IV fluid resuscitation to prevent the AKA. Earlier we discussed 4 ml per kg per hour should be our goal, with 200 to 300 ml per hour urine output. And also have to give loop diuretics, furosemide. And and also we have to treat the electrolyte abnormalities if it is present. In case of hyperkalemia, we can manage through ion exchange resins also, and in case of hypercalcemia also saline diuresis. And hyperphosphatemia present, we can try.
Ion exchange resin is used in chronic hyperkalemia, not in acute. Acute, you have to give either if ECG changes there, calcium gluconate, or insulin dextrose infusion, salbutamol nebulization, and Lasix, dialysis. Other one can prevent absorption of potassium.
And the complications are like AKA, acid-base derangements and electrolyte disturbance, and also there is possibility for DIC due to hypocalcemia. And there is also mechanical compression that can lead to the compartment syndrome also. If there is compartment syndrome, we can proceed with fasciotomy, and compartment syndrome can lead to complication of peripheral neuropathy. And the factors for AKA is hypovolemia and acidosis and tubular obstruction due to this myoglobin and inflammatory markers. There is also a score to predict the death or dialysis in the rhabdomyolysis, that is McMahon score, which includes creatine values, calcium and CK values, phosphate, bicarbonate, etiology, sex and age. And the total score, if it is 5 or less, it leads to 3% risk of renal replacement therapy or death. If it is equal to 10, there is 52% risk for renal transplant or replacement therapy or death. This score will help to determine the aggressive resuscitation who are at risk for complications of resuscitation.
So the main thing is when there is a muscle injury, you have to give fluids. So fluids are the mainstay treatment for rhabdomyolysis. You have to check the creatinine, you have to check the electrolytes. Okay? Thank you.
Thanks.